Good morning. My name's Natasha Roberts, and I'm here this morning with Andrea Nixon, who's a celebrity in the urology nurse circles. Andrea, would you mind telling us a bit about your career and where you're from?
So my name's Andrea Nixon and I work in Whangarei, New Zealand, which is at the top of the North Island. I've been a nurse there for the past 30 years, working alongside my husband Tony, who's a urologist. My career in nursing spans back over 50 years now, and I'm looking at retirement next year.
I really enjoyed your session and after the Margaret Janet oration, actually, where you spoke about your trainings and that your mother had done training in exactly the same place. It's quite an impressive career that you'd built over that time. Just thank you for doing that oration. What I wanted to talk about today is the session that we've just come out of where we were looking at addressing inequities in GU clinical trials. And you presented your work about your clinic in the north of New Zealand, and that you were doing clinical trials to actually improve access to treatment and investigations. After our discussion with the broader panel, do you have any more thoughts about your presentation and any thing that we could learn in Australia?
I think probably the interesting thing is, or the sad thing is, that though we have improved survival in cancers, the equity gap has remained unchanged, and that has been so for the last 25 years. We haven't breached that gap yet. And quite how we do that is a challenge in itself. We found it challenging to include Maori in our trials. We ran road shows where we went out into the local community, spoke with the GPs, and hoped that that would bring people into our trial groups as well. But that still seemed to be a barrier. There is a mistrust in going into trial work, I think. There is the lack of information in a language that they understand, which I think is something that we really need to build on. We unfortunately couldn't get anyone else in our urological circles to take on trials in urology, and so we've actually had to close that company. And so now for New Zealand, there is no one that undertakes trial work at all in both the East Cape area or in the Northland area, which are our largest population of Maori. So without that, how do we ensure that our Indigenous people have a place in trials, and indeed by having them in trials, get the best care and the best exposure to new medications and new treatments. In New Zealand, our health dollar is such that we still are unable to have such things as apalutamide, which is widely used in Australia for the treatment of prostate cancer, and still 12 years later from the trial that we did is unfunded in New Zealand. So that is also one of the huge barriers to living in a place like New Zealand. You have trades here that have all sorts of new medications, which you would love to see in New Zealand, but unfortunately there is no place for them yet. So quite how we do that, I'm not sure.
I understand there's barriers to accessing medications, but there's also barriers to get outpatient appointments and specialist reviews. And that seems to be a New Zealand wide thing. So it must be really amplified in the regional areas.
Absolutely. When we ran the public clinics, we endeavoured to have a one-stop shop, and there are centres that do that as well, where could come in for the single appointment and undertake an assessment, perhaps a prostate biopsy or a flexible cystoscopy if you were concerned about bladder cancer, etc. But still the barriers were to getting people into those clinics. You can say, well, we will give people money after the event. That's certainly something that happened in trial work. You would give somebody a petrol voucher after they'd attended the appointment. But for many of them, they don't have the car to get to the appointment, or they're reliant on family members who don't see their health as that important. And I'm not saying that people don't see their health as important, but there's the logistics as well. As you saw in my slide, we have a massive road slip which has taken out the main road from the coastal area of Whangarei into the city itself, which will take a year to open. So there are physical barriers as well as barriers from socioeconomic point of view. The fact that you have to give up a day's work in order to get to an appointment is a barrier. The fact that you have to travel along the beach at a low tide to get onto the road is a barrier, let alone the financial burden that puts on patients as well.
And so, what when you reflect on how you set up your clinical trials unit and your urology service, what what do you think you did really well? Like, uh, what can we learn from your successes and establishing a brand new a new service in a remote part of New Zealand, establishing trials in a remote part of New Zealand? Like, what hot tips do you have? What did you learn? There's a brains trust sitting here right in front of me. I don't want to. You want to be
Thank you.
retiring and
Thank you.
mountain biking or doing all
Well,
sorts
not
of
mountain
things.
biking.
Yeah,
Um,
I want
I
to be able to catch you. Yeah.
I think that we have to make trial work a little easier, and I think we touched on that in the program. That every time you do a trial, you go through the same process. I hate reinventing a wheel. I've done it so much in nursing, and I find that fellow nurses are wonderful at sharing resources. We actually have to make undertaking trial work easier. There has to be a sort of almost a national, why not an international agreement as to what trials will look like and how we can run those trials without us having to jump through the hoops. We should all get access to things like reimbursement for travel for patients or food or accommodation. That just should be standard across the board. If all that becomes standard and you take away some of that tedious work that has to be done, I think we need to centralise that type of thing more. We even need to centralise some of the Maori involvement. I know it's really important. We have always worked very closely with our own local kaumātua and our Maori advisors, and we had to have their consent to do a trial, and I do still think that that's really important. But I think the overarching way that we run trials can be much better streamlined so that we don't reinvent wheels every time. And I think we really have to work towards how we can access or have access to these medications, etc., to our people. And I think perhaps the travelling research bus sounds like an
Yes,
amazing thing.
it does
If
sound
you
like an
if
amazing
you can
thing.
have laboratory services on a bus along with trial coordinators, and you pick up your local urologist or your local oncology team, and they set aside that time that they're going to be on their bus and they're going to be travelling around throughout North Island, and you can access things like blood tests at the time, and consultations can all take place at that time and take place in a place that makes the people feel comfortable. It might be on their marae or their local hall where they have their family around them. For our people, that's very important. You very rarely will see a patient just on their own. They will always come with their daughters and their sons and their grandchildren, and they'll say, "Oh, you ask my granddaughter, she'll tell
Yes.
you." So I think it's important to include all of those. So I see perhaps the way of the future is things like the research bus. There is the technology, of course, of phones, etc. But in some of our rural places, you can't get telephone coverage,
Yeah.
or the people can't afford the program to
Maybe
run their
they need
phone.
a satellite on the top of
The
the
bus.
bus.
Exactly. So there's all those sorts of things that, because we can't reach our patients, some of our patients, to confirm appointments by their phone, by text
Yes.
messaging, because it's not switched on.
Yes, yeah.
So if you haven't made the appointment with that patient before they've left hospital, you're going to have no contact with them until you hope they're going to turn up for their appointment. And they're only going to do that if the car was going, or Joe could take them,
Yeah.
let alone try and put the petrol in the car. So
Yeah.
you've got to break down all those sort of barriers.
Yes, and keep it really straightforward,
Yes.
as simple as possible. So, what you're really talking about is community led clinical trials, right? If people are going to be meeting as a community, looking after each other as a community, then it's community led, community informed clinical trials.
Correct,
Yeah,
correct. You're
that's
also going to have
fantastic.
to have the medical people, and of course, as I said, in New Zealand now, that's becoming more and more of a challenge with
Yeah,
half the GPs. They're going to retire out of rural practice, and getting people into rural practices. I think governments are going to have to look more at certainly a financial reimbursement, and we hate to talk about the dollar, but that's a realistic thing to discuss. We love living rurally, but it's not for everybody, and we have to look at other ways that we can attract that, whether it's they pay off their student loans if they come into the rural. But I think we have to have more rural-based training systems so that rural people can get into medicine or nursing, and then those rural people will go back to
Go
their
back on. Yeah. I do like how in the session you brought up the technology might help. So maybe the bus will go there, and the satellite will be there for a telehealth consultation, and then people could maybe come and visit like once a quarter. I'm not sure. Like,
yes.
yeah. But then when people go to the area, they'll just they might go, actually, this is quite a nice place. And
Yes, that's right.
yes,
Exactly.
it's
It
the
exposes,
unknown.
that's right.
Yeah.
It exposes other people to what it is to live in a rural community, which is amazing and amazingly rewarding. Wonderful, wonderful people, so welcoming. So I said, you never go anywhere without sitting down first and enjoying some kai together. So that sort of thing is really important. It's about that sort of linking with people more than just I have a medical thing I need to talk to you about.
Yes.
You have to start with that whole discussion and that whole hello and how are you and who are you and where do you come from.
Yes.
Is really important. I mean, even when I spoke this morning, it was important that I told you my lineage, which goes back to England. That is who I am. So I had to tell you who I was and therefore why I am standing where I am today. And that sort of thing is so important in our culture. But thank you very much.
Thank you.
Yeah.
It was lovely chatting with you again, Andrea.
Thanks, Natasha. I look forward to seeing you perhaps in New Zealand next year.
Absolutely.
Although I've said
It's
I'm
in my
retiring.
calendar now.
Yeah.
It's all locked in.
I might have to meet you for a holiday afterwards.
Oh,
No.
love that.
Okay.
Love that.
Thanks very much. Thank you.